Hello everyone, welcome to Dr. Sam's anatomy classes. Myself, Dr. Azmi Mohsin. I'll be discussing a few MCQs with you now. Uh, so only I think 3 MCQs are there in this portion. Myself, Dr. Azmi Mohsin. You know this. Now this for question number 1. Which bone has the least chance of going into AVN after a fracture? Avascular necrosis, that is common with some bones or the parts of some bones, that after injury that portion of the bone goes necrosis. So which is the least chance of which bone is having the least chance of going into AVN after fracture? The options are talus, calcaneum, scaphoid, femur. So what will be the answer? Answer will be calcaneum. Okay. Why? Talus, remember. Talus, the parts of talus is a head of talus, neck of talus and body of talus. Right? Mostly it has blood supply from both the ends, but in few percent of the population the blood supply to the body is only from the head end. So in cases of fracture of talus at the neck, there are chances of necrosis of, remember, chances of necrosis in talus. AVN किसका होता है? AVN इसमें होगा, AVN किसका होगा? बॉडी ऑफ टैलस का, बॉडी ऑफ टैलस. Then scaphoid, majority of the person, they have blood supply to scaphoid. This is the first proximal bone. This is the one of the carpal bones in the proximal row, the lateral most bone in the proximal row, the scaphoid, which articulates distally with the trapezium. So scaphoid also has, normally it has, majority of the cases it has supply from both proximal and distal ends, but in minority of the cases the blood supply to scaphoid is only from the distal end. So in cases of fracture of scaphoid, there will be AVN of proximal segment. Remember, proximal segment. Proximal segment of the scaphoid will go into AVN. Femur is very common among these 4 bones. Head of femur, the chances of going into AVN is very more common in cases of head of femur in elderly, especially post-menopausal females above 55 to 60 years. This fracture neck of femur is very common, and also it might be a pathological fracture in this age group. So 90% blood supply to the head of femur is through the retinacular branches, right, from the neck of the femur reaching to the head of femur. Only 5 to 10% blood supply is through the ligamentum teres, the round ligament of the head of femur. Remember, these are the branches from the medial circumflex or the obturator artery to reach to the head of femur. So because the neck is fractured, 95% blood supply to the head of femur is lost. So this portion of head of femur, it goes into AVN. So in cases of femur neck fracture, there are chances of AVN of head of femur. Okay, so this is done. Now next question will be next question is the lining of urethra in males. Lining of the male urethra develops from male urethra. Remember the parts, it has the prostatic part, the membranous part, and then the penile part, which is subdivided into bulbous part and the spongy part, and don't forget there's a terminal part in the glans as well. So the entire length we are talking here, the lining of male urethra develops from mesoderm and endoderm, or ectoderm and endoderm, ectoderm and mesoderm, or from all the three germ layers. What will be the answer? So the answer here will be this, all the three germ layers, right? Because you know that if you remember the development of bladder, right? So the trigone, the posterior portion of the trigone actually that develops from the absorption of mesonephric ducts, while the rest of the urinary bladder that develops from the vesico-urethral canal, upper portion, from the primitive urogenital sinus, and that is endoderm, right? So and prostatic urethra posteriorly has this element of absorbed mesonephric duct. So prostatic urethra में development कहाँ से हो गया? From the mesoderm and endoderm. Then further continuing down, it is the endoderm. But what happens in the penile urethra, that is the suspended portion of the urethra, and as well as the below this in the perineum, this bulbar portion and spongy portion, it develops from this definitive urogenital sinus, the most pelvic part, and it closes like in a zipper like fashion from this proximal to the distal end on the inferior surface of the urethra, right? And this all is happening by this the skin covering here, this endoderm, which gets closed on the ventral aspect because of this plate, mesodermal plate, which joins and closes this urethra. But at the terminal portion, there is this ectodermal pit, which lines the terminal portion of the urethra. So the terminal portion of the urethra within the glans develops from ectoderm. So ultimately, all the three germ layers contribute to the formation of male urethra. Okay. Now, third question is, which statement is wrong regarding movements of the rib cage during quiet inspiration? Quiet inspiration is when you are subconsciously breathing. You are talking, you are running, you are doing everything, you are not bothered about, you are not conscious about your respiration. That is called quiet respiration. Or even think about if you are sleeping, let's say you are sleeping, that also is quiet respiration. So the question is, which statement is wrong regarding movement of the rib cage during quiet inspiration? Which is the wrong statement? First choice is the anteroposterior diameter of the thorax, anteroposterior, is increased by elevation of the first to sixth ribs. Is this true or not? You have to decide. The transverse diameter is increased by elevation of the 7th to 10th ribs. Is this correct? Vertical diameter is increased by the descent of the diaphragm. Think about this. Then a negative or suction pressure is generated within the thoracic cavity. Is this the cause of quiet inspiration? So you have to find out the wrong statement. Which is the wrong statement regarding movements of the rib cage during quiet inspiration? What will be the answer? Answer here will be, what will be the answer? The answer here will be this, right? Why this? First choice. The anteroposterior diameter of the thorax is increased by elevation of the first to sixth rib, means these, we are talking here as about the true ribs attached, sternovertebral ribs. These are true ribs. So then this movement actually is called the pump handle movement. Remember, pump handle movement is increasing the AP diameter by the movement of the upper ribs, but it is from 2 to 6 ribs. Remember, 2 to 6 ribs make this pump handle movement. Why 2 to 6 ribs? Because the first rib anteriorly has no movement. The two joints in the first rib anteriorly, first is the costochondral joint, which is a primary cartilaginous joint in all the ribs. Then the second is chondroesternal joint, which is actually a plain synovial joint in all of the true ribs except the first. And first, in case of first rib, the chondroesternal joint is again a primary cartilaginous joint, and you know that primary cartilaginous joint, after a certain time, they undergo fusion and there is no movement possible. Got it? So the first rib has no movement anteriorly. So the answer is this one. By the way, let's discuss the second choice. The transverse diameter is increased by elevation of the 7th to 10th rib. This is absolutely correct. This is, we are talking about the false ribs, right? These are called the vertebrochondral ribs, right? So these ribs anteriorly articulate with the cartilage of the rib above, right? So they do not reach to the sternum. So what happens is this: when you inhale, they actually ascend up, they elevate, and that movement is called this upper one. Remember, this upper one, this was the bucket handle. This movement is called bucket hand, sorry, this is called the pump handle movement, and this is called the bucket handle movement. Bucket handle movement, right? Because they increase the transverse diameter of the thoracic cavity. Then the vertical diameter is increased. Of course, this is correct, because the when you inhale, the diaphragm descends down, that increases the vertical axis of the thoracic cage, providing more of space for the lungs to expand, creating a negative pressure. Of course, negative or suction pressure is generated within thoracic cavity. Now, if the thoracic cavity is increasing in all the diameters, anterior-posterior diameter, transverse diameter, vertical diameter, there is automatically a negative pressure created, which of course is a reason for the suction of air in quiet inspiration. So the answer is, you have understood this. The answer is that the anterior-posterior diameter of the thoracic cavity is increased by elevation of 2 to 6 ribs, not from 1st to 6th rib. Okay, so that is been done. Okay, so there are more questions. The question is, fourth question is, the skin over the ligamentum patellae is innervated by which of innervated by or by a branch of which nerve? Skin over ligamentum patellae. स्किन ओवर लिगामेंटम पेटेली की बात हो रही है. सो लुक हियर, दिस इज द patella and here it is the ligamentum patellae. We are talking about the skin covering this ligamentum patellae, right? It's this portion. So question is that the skin over the ligamentum patellae is innervated by or by a branch of. Saphenous nerve is one option, anterior division of obturator nerve, lateral cutaneous nerve of calf, or intermediate cutaneous nerve of thigh. What will be the answer? Think about, oh shits, I think this can be brought back or not. Okay, anyways, so you decide about the answer. In the meantime, I'm drawing it again. This is the thigh and the leg. Here you find is patella, and this is the ligamentum patellae, right? And what we are talking is about the skin covering this region. What is the nerve supply of the skin covering this region? Yes. What is the nerve supply of the skin covering this region? This region. The answer will be, I believe, those students I have taught, they will be able to tell me, they will be able to guess the answer. And this is actually, Hunter's canal, the nerve passing through the Hunter's or the adductor canal, saphenous nerve, which actually is a deep nerve which becomes cutaneous here and it descends down on the medial side of the leg. This saphenous nerve gives a recurrent branch to supply the skin overlying the patella, and this is infrapatellar branch of saphenous nerve. Okay, so you got the answer, saphenous nerve. Then the last question here is, normally the position of umbilicus lies at which vertebral level? So answer, upper border of L2, lower border of L2, upper border of L4, lower border of L4. These are the options. You think. This is the plane which is, oh shit, anyways, just leave it. There's less of time now left, so I think this is an easy question. You can answer that way. You just have to learn actually the different planes, of the spine. So just fast, I'll just help you learning this up. Let's say this is L1, L2, L3, L4, L5, right? So just learn it here. This plane passing between L1 and L2, it's called transpyloric plane. This is transpyloric plane, right? And this plane passing between L2 to L3 is subcostal plane. And this plane passing between L3 to L4 is called transumbilical plane. And this plane passing between L4 L5 is called transverse tubercular plane. This is through the iliac tubercle, which is present 5 centimeter behind the anterior suprailiac spine. And this plane between L5 and S1, this is trans-ASIS. Okay, and if it is asked that what is the plane passing to the highest point of the iliac crest, it will be L4. This is highest point of iliac crest. Okay, so the answer to this, you have got to know that umbilical plane passes between L3, L4. The answer will be upper border of L4. Okay, so we are done here. Good luck.